Well, good evening, ladies and gentlemen. To those in the room here tonight and those of you, the many of you, I'm told, streaming online, I'd like to welcome you on behalf of the Peter Doherty Institute for Infection and Immunity and the Murdoch Children's Research Institute to COVID-19 vaccines. Your questions answered by some of the best experts in the business. My name is Michael Rowland. I'm the co-presenter of News Breakfast on the ABC. Yes, I'm still going since about 3 o'clock this morning, so my apologies in advance for that. And for those of you who might watch the show or indeed consume any media, I and every other journalist have been living and breathing COVID for the last 12 months and now living and breathing the vaccine rollout. I'd like to begin by acknowledging the traditional owners of the land on which we're meeting and the traditional owners of country throughout Australia. Where you may be watching, I pay my respect to their elders, past, present and future. The good people at Doherty have many abilities, but it turns out prescience is among them, because the last event I moderated for Doherty was in this very room, and Sharon knows exactly where I'm going here. It was back in September 2019, and the title of that talk, Pandemics, Pathogens and the Environment, Understanding Threats to Our Health. So it was a very prescient conversation, and here we are 15 months later. Now, as Australia begins to roll out COVID-19 vaccines, we are faced with an absolute abundance of new information, technical terminology, and sadly, lots of vaccine myths and misinformation. It can quickly become very confusing and overwhelming, and it's understandable and natural that many of us have questions or concerns. I have questions, and I'm deep into this every single morning of the year. The Peter Doherty Institute for Infection and Immunity, as many of you would know, has been at the absolute forefront of the COVID-19 pandemic response. It is a joint venture between the University of Melbourne and the Royal Melbourne Hospital. The Institute was purpose-built to bring together experts in infectious diseases and immunology in order to find solutions to prevent, treat and, importantly, cure infectious diseases. 700 staff were brought together so they could tackle the exact issue we are facing today, and it's fair to say they have all risen to the occasion. From clinicians treating patients in hospitals, scientists continuing to perform tests on suspected cases and viral genomic sequencing, epidemiologists working closely with the state and Commonwealth governments on policy, and hard-working researchers working on antibody tests, treatments and a vaccine. Their staff have been at the coalface of this pandemic. The Murdoch Children's Research Institute, MCRI, is the largest child health research institute in Australia. Over the past 12 months, MCRI has made a number of very important contributions to the world's knowledge around COVID-19's effect on children and their families. MCRI researchers examine children's and families' immune systems to determine household transmission dynamics, a very important subject, and showed how children's immune systems protect the majority of them from the worst effects of COVID-19. MCRI experts conducted an extensive evidence review to reassure parents and teachers that schools were safe places and were instrumental in working with the Victorian government to help kids return to school before that statewide lockdown was lifted. The clinician scientists began the world's largest trial of the BCG vaccine to help reduce COVID-19 severity and to test whether it improves immune responses to COVID vaccines. And finally, MCRI's specialists in vaccine uptake and acceptance have worked tirelessly to inform, educate, reassure and encourage Australians to accept a COVID-19 vaccine when it is offered to them. And as we know, the rollout is well and truly underway. We'll be talking a lot about that in just a moment. As I mentioned tonight, we have an esteemed panel from here at the Doherty Institute and MCRI to answer those questions you might have about the COVID-19 vaccine rollout. So let me firstly go from my right across the panel and introduce Professor Sharon Lewin. She is the director of the Doherty Institute. Sharon is an internationally renowned researcher in HIV cure and infectious diseases physician. She is also the chief investigator of an NHMRC Centre of Research Excellence. It is called the Australian Partnership for Preparedness Research on Infectious Disease Emergencies, or APRISE. Love those acronyms. It aims to bring together Australia's leading experts in clinical, laboratory and public health research to address the key components required for a rapid and effective emergency response to infectious diseases. Please make Sharon Lewin very welcome.
Thank you.
To Sharon's right is Associate Professor Margie Danch, and Margie is a consultant paediatrician at the Royal Children's Hospital and Associate Professor and Clinician Scientist at the University of Melbourne and the Murdoch Children's Research Institute. As a leader of the Vaccine Uptake Group, Margie's research focuses mainly on vaccine confidence, acceptance and uptake, particularly amongst high-risk groups and in low and middle-income countries. She works closely with the World Health Organization and Global Vaccine Demand Hub and is a key part of the Melbourne Children's Global Health Leadership Team. And I'm pleased to report Margie has received the first dose of the vaccine. Please make Margie welcome. To Margie's right, Professor Terry Nolan. Terry is a paediatrician and clinical epidemiologist and head of the Vaccine and Immunisation Research Group at the Doherty Institute. Terry was Associate Director of the Murdoch Children's Research Institute in the late 1990s and has continued an appointment there as a Professorial Research Fellow and Head of the Vaccine and Immunisation Research Group. Terry's research has been principally in immunisation and clinical trials of new vaccines. He is a former chair of ATAGI, which is the government's principal advisory group on vaccine use, and is also an advisor to the World Health Organization on vaccine use and safety. Please make Terry Nolan very welcome. And last but not least, at the very end of the panel is Dr. Janine Trevelyan. Janine is the Head of Clinical Virology and HIV Services at Austin Health. Janine is the lead of the Austin COVID-19 Vaccination Hub. She has been very, very busy for the last couple of weeks. She is responsible for coordinating vaccine distribution across the northeastern region of Melbourne and establishing large vaccination clinics for high priority groups such as healthcare workers and the general public. Janine is an infectious diseases physician and clinical researcher whose work focuses on understanding and preventing the long-term complications of viral infections and in particular the effects of HIV. And I'm extra pleased to report Janine has received, I think just today, the second dose of the vaccine. So Janine's vaccined up. Make her very welcome.
Thank you.
Now, before we get started, looking forward to the many questions we have online already and contributions from you in the audience. We'd like to share this event on social media, so please use the hashtag COVID-19 Q&A and make sure in doing that to include the Twitter handles of the Doherty Institute, which is at the Doherty Inst, I-N-S-T, and the Murdoch's Twitter handle at MCRI_for_kids. Now, as I mentioned, I've got so many pre-registered questions coming in already from our very large online audience. To those in the audience, please raise your hand if you have a question. I'll invite you to the microphone in the middle of the room. And when asking your question, I ask that you please remain respectful to our panellists and all the other guests in the room. That would be very much appreciated. Alternatively, you can use your smartphone, if you have one, to access the live stream code chat function by scanning the QR code. And finally, for those viewing online, please use the live chat function to ask your questions. Okay, let's get to those questions, and I'll hog the first question because that's the moderator's prerogative. I want to start with the story we were covering on News Breakfast this morning. I'm sure it's an issue front and centre for everybody today, and that is the concern raised in some European countries over a possible, and I underscore the word possible, connection between the Astrazeneca vaccine and blood clots. The Australian government has moved very quickly to assure Australians the AZ vaccine is very safe and insists there is no evidence of that connection. But I want to start with you, Margie. I know you've spent a large part of your day speaking with vaccine experts on this very issue as it erupted this morning. What have you learnt and what's your perspective?
Yeah, thanks, Michael. So we know there's about 12 countries now in Europe that have actually suspended their programs, more recently Germany. And this is around this concern that blood clots may be caused by the Astrazeneca vaccine. And what we mean by that are blood clots in the legs or the lungs or the brain that can make people very unwell. And there have been, I think, up to 3 reported deaths now. So, of course, the most important thing to understand is that these thromboembolic events happen in the community. There's a baseline rate of how commonly these occur. So, for example, in Australia, we might expect up to 17,000 of these events per year. So it's really important when we are thinking about these events and we think of the size of the vaccine rollout that's already occurred in the UK and across Europe. There have been 17 million people vaccinated. And for example, in Europe, of the 5 million vaccinated, there have been 37 thromboembolic events. So what we really need to understand is we need to look at how many people have been vaccinated, how many events, but how does that compare to the background rate? And at the moment, the WHO, the European Medicines Agency have all come out very strongly, as has Australia, the TGA, and said that there is no increase above the background rate. Unfortunately, these things are going to occur in the community. We're going to be vaccinating millions of people. So there's actually no reason for alarm. I think the reason it's been suspended is out of caution. But the problem is by suspending it, we actually cause people to worry and we really impact their confidence. But I, like everyone else, really want to reassure people that there is no signal at the moment that we should suspend our program.
Sharon, do you have a view on this? And just picking up from Margie, it'd be very unsurprising if there weren't these issues as the rollout gathers pace, these, for want of a better expression, teething problems emerging. Is this to be completely expected?
Absolutely, and you may remember we had the deaths in Norwegian nursing homes initially. So you have some events, and the question is, are they occurring at a greater frequency than they would normally, and are they associated to the vaccine? What I would like to really reassure people about is that our government are constantly looking at this sort of data in real time. It's being shared around the world. You may then ask, well, why does one government take a different view to another? And that's probably related to their individual risk thresholds within their countries. But I have great faith in the way our government deals with this sort of data, the Therapeutic Goods Administration. They look at it carefully, they look at the baseline rates, they bring in experts, and then they decide, yes, it's a signal, or it's not. Very tricky, and we're going to hear more of it. But in this particular situation, based on the numbers that I'm reading, which is similar to what Margie just mentioned, I don't think there's concern. I don't think it's a good thing to just put on hold just in case.
I want to turn now to the fact that the rollout's happening. The majority of Australians will get the Astrazeneca vaccine. The Pfizer rollout has happened for the first stage for healthcare workers, quarantine workers and the like. Terry, and I'm just paraphrasing so many, dozens of questions along these lines. There is concern by people who know they are destined to get the Astrazeneca vaccine and say, well, why can't I get Pfizer? Because, hey, I read Pfizer's much more effective than AstraZeneca. How would you answer that question? How would you try to, I guess, reassure people along those lines?
Well, it's not true that one vaccine is much more effective than another. Of all the vaccines which have been now licensed into some level of emergency use or provisional licensure around the world. And as the data are now appearing from, the clinical trials were big enough. The clinical trials were 30,000, 40,000 individuals, huge numbers. But now we're seeing vaccine data or vaccination data from populations, hundreds of millions of people now being vaccinated around the world. And so what's called real-world data studies are now appearing of those implementation experiences around the world. So we started off with one of the issues, is there a concern about an adverse event? But in fact, the real story has been the massive evidence already of huge benefit. So various ways of asking questions of the data to estimate whether in fact deaths are being prevented or hospitalisations are being prevented from a number of studies, the earliest from Scotland, from England and recently from Bristol, have all shown, first of all, that the Pfizer and the AstraZeneca vaccines are delivering roughly equivalent protection against hospitalisation, against severe illness and so forth in the UK population. So that's a very, well, it's an interesting coincidence that we have the same vaccines that they have in the UK. So I think Australians can be really reassured about those early data. Those early data are in very large numbers of people, by the way. 20 million or so have been immunised in the UK. We're very happy. We've immunised a few thousand in the first weeks here, but they are well and truly in these massive numbers with these really strong beneficial bits of evidence now that's highly effective.
I'll turn to one of our online questions. And a reminder, please, if you've got a question in the audience, raise your hand. I would like to hear from you personally. John asks, do the AstraZeneca and Pfizer vaccines cover all strains of the COVID vaccine? For example, the UK strain, we've got a South Africa variant as well. or are the vaccines specific to the country in which they're given? Janine, do you want to buy in on that?
Yeah, it's a great question. It's becoming increasingly important as we learn more about different COVID variants, is sort of the phrase that people are using. We know that as viruses grow and spread that they can change over time. That's normal for all viruses. And we know that some of those changes may mean that they are less responsive to a vaccine or have more chance of escaping from a vaccine, is perhaps a better way of putting it. It's not to do with necessarily the country that you're in or even actually the country that we name them after. We probably shouldn't do that anymore, to be honest, because you can get these variants anywhere where you're catching COVID. And the real answer is that we have some evidence that some of the vaccines are not as effective against some of the variants, but that we don't know that for all of the vaccines, and we don't have any good evidence to say one vaccine is better than others, which I think is the more important thing. My instinct is probably that we're going to have, some issues with some of these variants with all of the vaccines down the track.
Anybody else want to buy in on that? Sharon?
People have heard about probably the most common is first described in the UK, and I think we've got more and more as real world data that Terry was talking about, both from the UK and from Israel, where the Astrazeneca vaccine in the UK and Pfizer vaccine in Israel had been used in populations where the UK variant was common. And it had similar efficacy, it looks like, in the real world of both Pfizer and Astrazeneca against the UK variant. The variant that we're worried about a little bit more is the South African variant. And the reason why we're worried about that is because when you look in test tube models, if the vaccine works or not, the South African variant does look to be harder to stop growing than the other variants. And we don't have any real world data yet for Pfizer and the South African variant, meaning clinical trial data. And we do have some data from the Astrazeneca vaccine because it was tested in South Africa, where the dominant variant is this South African variant. It was a small study and they only looked at mild to moderate infection, and the efficacy was indeed reduced. We don't yet know how good the Astrazeneca vaccine will be against severe disease, which is what we worry about. And some of the other vaccines, which don't yet have in Australia, which is from Johnson & Johnson and Novavax, they've actually been tested in the UK, US, South America or South Africa, and they all do less well in South Africa. So I think the South African variant's the one that we're concerned about.
To another question along the variants line, this is from one of our pre-registered guests, if vaccines become available later, say in 6 or 12 months, and they're effective, they're proven to be effective against the variants, the UK, the South African variant, should a person already by that stage, we're casting forward 12 months, already vaccinated with either AstraZeneca or Pfizer, take the new vaccine, or would their existing vaccine be fine? Terry?
Don't wait. It'd be madness, really. First of all, we don't yet know for sure that the variants are going to require modifications to the vaccines. It's likely or possible, but not certain yet. Secondly, having a primary vaccination from what's called the original strain of the virus is still going to give you a very good platform or basis of immunity, which you can tune up later on if necessary by having a booster from one that's a more fine-tuned vaccine, which is aligned with the mutation that's provided that variant. But it would be madness to think, well, wait for the day when the real virus comes, because it's very likely that the variants will continue to emerge over time. Fortunately, but people need to understand the basic principles here. The more infection you have, the more likely it is that these mutations will occur, because there's more virus circulating in the world. If we're very successful through both public health interventions and also vaccination at reducing the amount of infection, then the mutations will actually reduce. This virus is fundamentally more stable than flu. Flu is a really unstable virus. It doesn't fix itself. This virus does fix itself reasonably well, but not if it's massively growing in hundreds of millions of people as it is now in the Northern Hemisphere in particular. So the first thing to do is reduce the amount of infection around the world. That will reduce the mutations. And the second is produce boosters if we need them that are going to tune up and then boost the platform of a very good vaccine, which we should be getting in Australia as reasonably quickly as we can.
Yeah, you mentioned flu. I want to turn to the rollout questions, of which we have many with Janine in just a moment. But again, a common theme of the questions, we all get, or most of us get our flu vaccine every year. So should people still get that, or would it counteract the effects of either the Astrazeneca or Pfizer COVID vaccines?
So if I may, because this is an issue we're dealing with at the moment, we want to start a study at the moment, a co-administration study with some of the manufacturers to actually find out if there's interference between the flu vaccine and the COVID vaccine. It's unlikely to be the case. Interference means either your immune response is reduced, or perhaps it'll give you a more unhappy experience with reactions to the vaccine. The only way to do that for sure is to study it and give the vaccines at the same time. So in the meantime though, there's no problem with having the flu vaccine either before the COVID vaccines or in between them. And frankly, we're all a bit concerned that we may, having had almost no flu last year, a bit concerned that we may actually have an unusually active flu season this year. That worries me a lot actually. And so I think the importance of getting flu vaccine is probably much greater than it has been in the past. We had very good coverage and uptake from flu last year because we didn't know what was going to happen. As it turned out, there wasn't very much. But we've seen with another virus called RSV, we didn't have any RSV circulating last year, probably because of social distancing and so forth. But over the summer, we saw the flu. It's normally a winter virus. Yeah. We saw that virus have a winter experience over the summer. That's very worrying and is one of the possible portents of what might happen with flu. So really important to get your flu vaccine.
Margie, you're nodding your head vigorously. Does
yes,
that concern
I've been
you?
having these conversations today in immunisation clinic with parents around, giving their children the flu vaccine, and I would encourage everyone this year. I think it's super important that they get the flu. And yes, we are recommending a couple of weeks separation from the COVID vaccine and the flu vaccine for adults. Of course, the COVID vaccines are not recommended for children under 16 at the moment, but very important to get the flu vaccine this year.
Now, Janine has been at the coalface of the rollout at the Austin Vaccination Hub, working very hard, vaccinated herself. A simple question, how will I be notified to take the vaccine? We get asked that on our show a fair bit. We've all seen up here the 1A, 1B, 2A, 2B groups. That's fine, and you can quickly detect where you sit in those groupings. But physically, say I'm at the risk of dating myself. I'm 52. I'm in Group 2A. Is that right? I think.
Yeah.
Even I don't know. So physically, how am I told? Does my GP ring me? Do I have to ring the Austin or ring my GP?
Yeah,
how do I get vaccinated?
It's a really good question, and unfortunately it is one of the questions that hasn't been worked out exactly yet. Where does yourself or anybody sitting in this room, how do they exactly know when they're coming in to get vaccinated? And it's easy with the 1A when everybody really is, it's based on your employment is how you end up in 1A. Where do you work? Do you work in hotel quarantine? Do you work in a hospital? But then once we're getting out into the general community rollout, it does become a little bit trickier. So I don't yet have the answer for you. Will you get a text message? Will you get an email? And where will that come from? I can tell you that there will be lots of places where you'll be able to then go to get your vaccine. And that's really, I guess, part of what we've been working on very closely is trying to create the capacity so that when it is your turn, you can get into a vaccine clinic and get vaccinated very quickly, but that you can also do that in a centre that suits you. So will it be perhaps coming to the Austin Super Clinic, coming out, getting vaccinated out there? We'd love to have you. Or will it be that you actually prefer to go to your GP? I mean, if your GP's been one of the people who has been assigned as a COVID vaccination GP clinic, that might be what you prefer. Or you might prefer to go to one of the smaller clinics that are being set up. And it's really the idea that there actually are going to be a number of different centres that will suit different people, with the idea that overall the capacity will allow everyone access to vaccine.
Margie and Sharon, I want to bring you in here. Margie, we were talking about this before coming up about messaging, and I want to sort of roll in two questions to the one. The first one is, what is the government doing well and poorly in vaccine promotion messaging? What would you change? And I'll bring you in as well, Sharon. And also, how's the engagement going with the hard-to-reach populations like refugee and migrant communities that have low health information proficiency? I'll kick off with you, Maggie.
Yeah, so I think the Commonwealth Government has been, running a really good campaign broadly across the community to initially address people's questions around the vaccines that are going to be rolled out. As you said, the phases of the rollout, I think the messaging is starting to come through now about how this is going to happen through the hospital hubs in 1A and then in 1B for the other groups through primary care and through general practice. So I think that sort of information has been communicated well. I think there's still a lot of room to really address the specific concerns that people are worried about, and we know from a lot of the work that we've been doing through surveying now up to 5,000 people in Group 1A and 1B, and really trying to understand the different concerns that people have depending on what group they're in. And we know that the number one concern is around vaccine safety. And universally questions around, the speed, how quickly the vaccines have been developed, the different vaccine platforms that have been used, those sorts of questions. I think people need a lot more reassurance about those key questions because they're coming up again and again and again, separate to the vaccine effectiveness, how well do they work, the strains and so on, which are really important. So I think we really need to get this messaging out more broadly. And as you said, really we need to be working closely with communities through First Nations and Indigenous community leaders, strong community engagement, and not just through TV, but through radio, community forums, discussions like this. And similarly in a lot of the smaller minority groups and the cold communities. So I actually think there's a lot of room for us to really engage and improve our communication, and we're working very hard on that with the state government at the moment, and I'm sure Sharon would like to expand on that too.
Yeah, I don't have a lot to add, but just so that there's sort of a two-layered system here. You've got the Commonwealth Government doing a lot of communications, but then every state government does its own communications. And I think, just picking up what Margie was saying about community engagement, I think we really need community leaders that are very empowered with a lot of knowledge, not necessarily medical, but trusted people in their communities, whether it's priests or rabbis or imams or whoever it is, or teachers that can really share a message that's digestible. And I heard about a great program by the Victorian government recently, which is a mini grant program for communities to submit some innovative ideas. I'm sure there's a fantastic history of very innovative public health messaging, and often people sitting in Canberra don't necessarily know what really makes people motivated about something. So this sort of small grant program sounds a great idea, what we'll do locally.
And Michael, if I might add to that also, we've seen some fantastic messaging coming out of the US and the UK. There's been a wonderful video that's come out from the US for black people and black communities where questions are being addressed by black scientists and nurses and doctors, and really, quite funny, but also really clearly communicating messages from people that, people in those communities are going to trust. And similarly in the UK, using some celebrities, like Michael Caine or Elton John, and I think we've all seen Dolly Parton's video. People really want to relate to those people and understand, what they think, and they've had the vaccine. And so I think we really need to, as Sharon said, we need a lot more engagement and discussion.
We need an Australian celebrity, don't we?
Yeah, we do.
Any suggestions? Well, I've got one. I was laughed at the studio. I suggested Kylie Minogue, who could reframe locomotion to everybody's getting the vaccination. I won't try to sing it. I can't sing.
Please. I love it. I was about to say Kylie myself.
Sign her up.
Just showing my age.
She's very popular. Yeah, you and me both.
But actually, Michael, can I just say also on that, it's really important, I think, that it means a lot for people to see other people getting vaccinated in the community and it becoming the social norm. I think a lot of fear will be broken down when people say, I've seen people being vaccinated, they're fine, they haven't had a bad reaction. Rather than just bombarded with information, we actually need to make that more visible.
Yeah, and I know they get criticised in some quarters, but it's very important for our political leaders, the Prime Minister, the Premiers, the health ministers to get vaccinated just for that community messaging as well, isn't it? It's so important.
Absolutely.
Now, I've got a hypothetical for you, and please, again, don't be shy, people. Really welcome your questions, so just raise your hand and the microphone can be yours. We'll get to some of the more online questions in just a moment, but this is a pre-registered question as well. It's a hypothetical, anybody can chip in. I hope you go to the United States in May for business. Good luck. And to see more importantly, to see my 3 children who live there. Gee, that must be hard. I'm 70, so in phase 1B, if I get my first jab of Astrazeneca before I leave, is it safe to get a different vaccine for the second dose? For example, the US does not offer Astrazeneca. Is that possible? Is that advisable? Janine, you're shaking your
Yeah,
head.
no, that's definitely not advisable. What we know now, it's fairly strong advice, is that whatever dose, whatever vaccine brand you get for your first dose should be what you get for your second dose. And that's really because that's all the trials have been run with the one brand. We don't know what happens if you mix brands. Now, there are some trials running at the moment to see what would happen if you do that, but very strongly the recommendation is have the same brand twice.
Okay. So I hope that 7-year-old is listening and takes that advice. Chris asks online, hello, can you get the vaccine if you're sick, for example, with a cold or flu? If not, then how long should a person wait after being sick with the cold or flu to get vaccinated?
I would say that, you know, as we do with childhood vaccines, if someone has a fever, they should not receive a vaccine. But of course, you know, coughs and colds through winter are common. So I think if you've got, you know, a bit of a cough or a runny nose, that's fine. But we don't recommend, you know, vaccination with a fever over 38.
And on that same line, Roz asked, what vaccine options are there for immunocompromised patients such as cancer sufferers, Sharon?
At the moment, all vaccines are recommended for all people, including immunosuppressed people who have cancer or transplantation or other immunosuppressive illnesses. But we don't know a lot about these vaccines in immunosuppressed people. Some immunosuppressed people were enrolled in the big studies, and we're now getting some real world data coming out. There's no reason to think that the vaccines would be unsafe in immunosuppressed people. The concern is whether they will work as effectively. There's no evidence to say they don't work as effectively yet. I think we'll learn more, but we do know that immunosuppressed people have a tougher time with COVID, so I would be getting a vaccine now. We will learn more over time which might work better in immunosuppressed settings.
This next question is up your alley, Margie. Kasmira asks, can you please discuss the current recommendations for breastfeeding women in terms of the available vaccines?
Yeah, this is a really big question for women at the moment. And what we say is if people are breastfeeding, it's safe to get the COVID vaccine. And similarly, if they're considering falling pregnant, it's okay to get the vaccine. We just at the moment are recommending not to receive the vaccines in pregnancy. Although having said that, these are inactivated vaccines, they're not live vaccines. We give other inactivated vaccines like flu and whooping cough very safely in pregnancy, and they work really well. So we actually don't have any reason to be worried about these vaccines in pregnancy. We just don't unfortunately have the clinical trial data yet, but that will come. So for some people who are at higher risk, if they're working on the front line or in the ICU and the emergency department and actually are at higher risk of getting sick from COVID, then it might be a very valid choice for them to have a vaccine in pregnancy if that's what they choose. But certainly in breastfeeding at the moment, we don't believe there's any reason for concern.
Terry.
Just add, we're about to start a study in pregnancy of one of the COVID vaccines, the Johnson & Johnson or Janssen vaccine in Australia, so that there will be an opportunity for pregnant women to participate. There is, as Margie says, there's no basis to suspect the vaccines will be harmful in pregnancy, either to the mother or to the fetus, the baby, but we do need the data to reassure us. There have been and will have been many pregnant women who will have been immunised around the world inadvertently, and that experience is also being looked for and studied at the moment in those hundreds of millions around the world who've been immunised. So we've heard no signals, bad signals about that at this point. We don't expect to hear them. But we do need to do those studies, and we also need to do studies in children, which we'll probably get to later in the questions.
Yeah, well, I'll get to that now. Whether or not children end up being vaccinated, as far as I know, none of the vaccines have been deemed safe for children under 16.
Well, they have been studied under the age of 16,
right.
And only one under the age of 18, and that was the Pfizer down to 16.
Do you see a situation once the rollout goes on for teenagers and younger kids to need to be vaccinated, Sharon?
Well, at the moment, we need to know how they work in children and what efficacy they have. And yes, I think so. I mean, COVID is very different in children than in adults, far less likely to get sick, and there's probably less likelihood of transmission. But to overall reduce the amount of COVID transmission, I'd expect that we would be vaccinated children. I'd be interested in what the others
Yes, so I'll go around the grounds here, Margie.
Yeah, no, I think we will get to vaccinating children when we have the trial data. We get asked this all the time from families. It'll be late this year, early next year, we don't know. But I do think children will be offered the vaccine, and we don't have reason to suspect it will be unsafe in children. We commonly get asked, will children with medical conditions, at-risk medical conditions, get it first? Are they more at risk? And we just don't have that information yet. But what do you think, Terry?
So we haven't got to the herd immunity question, which is really begs the question about whether children should be vaccinated, because not just for their own protection, but will we be in fact contributing to the protection of the oldies in the community who aren't vaccinated by increasing the total fraction of vaccinated and protected individuals in the whole community. It's hard to see us achieving that without vaccinating children from the age of 18 down, and possibly right down even to preschool age. So again, we're also starting a study in Melbourne and elsewhere in Australia in children shortly, as part of an international study, again with another of the vaccines, not one of the ones that's at the moment being purchased by the Australian government, but a similar vaccine. And we're hoping to actually add to that knowledge by showing that it both works properly in children. There are questions about the dose. Do kids need less or more? Do they need 1 or 2 doses? Those sorts of questions have to be asked. And also data around safety. We don't need to do massive studies like we did in the adults to show the vaccines work, because we know enough with antibody responses to be able to infer protection in knowing what the immune response was in those children.
And Janine, do you have a...
No, I agree. I mean, instinct says that we will be vaccinating children. It's not ready yet. It's not licensed for children. We shouldn't be doing that at the time, but I think we need the data, and I suspect that's what will happen.
Okay, I've got a lady here in the front seat. Would you mind going to the microphone to...
Got a question. With the incidence of active COVID here so low in Australia, how are we monitoring? I know we look at our overseas and see the success of the vaccinations, but are we going to do some follow-up antibody results on doctors who come in contact, or what's Australia going to be doing to actually see the results of the vaccine, or are we only relying on overseas results?
Yeah, really interesting question, Sharon. When we roll out a vaccine into the community, and Terry referred to this earlier, we're getting real-world data of vaccine effectiveness in the community. We're not going to be able to judge that here because we've got no COVID, but there's a lot of questions that we can answer around what's happening to our immune system in response to the vaccine, because we're quite unique because we've got no exposure to the virus itself. And so you've got this pristine population receiving a vaccine. So there's a lot of interest on research to be done on the immune response in different populations, in people that have had COVID before, in immunosuppressed populations, and the elderly. There'll be a lot happening, but we won't be doing that real-world effectiveness studies that we're reading about from the UK and Israel, etc.
Thank you very much for the question, and please don't hesitate to follow the lead there. I want to go to QB, who asks the $64,000 question: what is herd immunity and how does it work? Terry, you touched on it before, so you can dive in.
I should pass because I've already done my bit on this one. No. So herd immunity is where you have enough of the whole population protected that there's so little opportunity for viruses to circulate because there are so few people who are not immune. And if you can get to that threshold, and mathematically you can actually calculate what it is depending on what the virus characteristics are and so forth. But for this virus, it's probably around 70% or so of the population need to be protected, either from having been infected already, which thank God in our country is not the case. We have a tiny proportion who've been infected. If they've been vaccinated is the only other way in which really that can happen. So hence the question about children. Are children really going to contribute to this? And vaccines don't work unless people actually get them. So it's all very well to talk about these great vaccines with very high levels of efficacy, but if we only have 50% of the population getting it, then the other 50% won't be protected because they haven't been vaccinated. So that's why some of the pessimists in the US at the moment are looking at the whole US situation and saying, well, look, when you add up vaccines which aren't completely perfect, maybe only 60% of the population in some states will get vaccinated, and we're not vaccinating children, the best we can get to is about 40 or 50%. And therefore herd immunity may not be achievable. I hope in Australia that won't be the case, and we will be able to achieve it, and then that makes a huge difference long term in how we have to manage this virus.
And can I just add to that and also say it's really important, I think, for people also to understand that for them to get the vaccine and to contribute to herd immunity, they're also protecting the more vulnerable in the population. So, you know, the elderly or those with, you know, at-risk medical conditions. So, you know, reaching that threshold is super important. And I agree with Terry, if we're going to reach, you know, 60, 70%, we're going to have to really nail this rollout in terms of a lot of the practical barriers and the supply issues and getting, you know, the vaccines into the GP clinics. There's so much around that, as well as people being concerned about whether they will have it or not. So it's really just important for people to realise that reaching that threshold, there's many factors that, you know, feed into the coverage we reach.
Lots and lots of questions about side effects of the vaccines. We have a living, breathing case study right here at the end of the panel.
Both living and breathing.
Living,
An
yes, most
excellent
importantly.
example.
That's great. That is a really good start. I'll just bring that down to one sort of common theme. Could you please share what percentage of patients suffer any side effects from the COVID-19 vaccinations? Does it vary amongst the different types of vaccines? And what sort of side effects can people expect to suffer?
Yes, so I can tell you the evidence and I can give you my personal experience as well. So we know that with these vaccines that actually most people will probably get a mild side effect with it. So I know Margie got a bit of a sore arm, couldn't lie on that arm, but you know that's probably a price worth paying. And somewhere around 80% of people will have that, have a sore arm the day after. And then there's a kind of a range of those sort of symptoms that we associate sometimes with vaccines. Headaches, feeling a bit achy, feeling a bit sort of hot and cold, feeling a bit tired. And that's quite common. So somewhere around the 50-60% of people will get a mild version of that, but it's not enough to stop you going to work. You know, so for instance, I'm here today, I feel pretty good. You know, I feel a little bit less good than I did yesterday, but only mildly. You know, I'm aware that I'm perhaps like you would if I'd had a little bit of a cold and you just don't feel 100%. That's what most people will experience. Mm-hmm. You know, a very small percentage of people will become unwell enough to perhaps need to take a day off work. So that's kind of another, you know, divider. And what we're seeing overseas is it's about 3%. But even those people, it's just a day or two at home in bed. And the TGA are doing a great job releasing each week a record of people who've had adverse events, and it's really very low in Australia so far. So it comes out every Wednesday, so we'll get it again tomorrow. But you know, so far it's about 300 people in Australia who've had an adverse event, and even those, most of them are mild.
Margie, how's your arm?
Yeah, no, my arm was only sore for about 24 hours, which was really good. Yeah, not too bad at all. And I didn't have any of the other systemic side effects that you're referring to. I wasn't achy, wasn't tired, so felt, you know, actually a bit sort of like a superpower, you know, after it.
And I might say to it, overall, the frequency of these sorts of non-specific general effects is lower with Astrazeneca than Pfizer. Yep. And we also know that the adverse events are worse in the second injection with Pfizer than the first, so it can be increased. And they can be easily dealt with, you know, Panadol, paracetamol, or any anti-inflammatory. And the recommendation is not to take the paracetamol before. Okay. And then there's a few rarer side effects that are coming out of more severe local skin reactions that we're seeing with the mRNA vaccines, but they're very rare.
And it doesn't hurt, does it, Janine?
No, the actual vaccination doesn't hurt at all. In fact, that's the most common thing we hear in the clinic. I think because everyone is a little bit worried, and I understand that. People come to the clinic and they sit down and they're greeted by one of our lovely nurses, and then every single person universally turns to the nurse and says, I didn't actually feel that at all. and we've had a couple of people suggest they hadn't been vaccinated until they the next day were quite aware. Yeah.
So, Mike, I can't resist, but we're both paediatricians. As a paediatrician, one of the first things you learn is never to lie to a child. So you never tell a child it's not going to hurt when you know it might hurt. So you say to them, look, this might hurt a little bit. If it does, it's going to go away very quickly, and make a little joke about it and so forth. Yeah. But yeah, and it's the same with adverse events with vaccines. Yeah. Don't pretend that there aren't going to be side effects. Of course there will be, but the overwhelming evidence is that they're trivial or very mild. And equally, there may be some more significant side effects, of course, but you've got to look at the risk-benefit. What is it that you're preventing by experiencing this modest degree of discomfort, preventing death or severe illness, not just in you, but also contributing to herd immunity and protecting others in the population?
A couple of other side effect questions for people who have anaphylaxis, where it's not specific to, say, one thing, for example, peanuts, but from various reasons or instances. Are there precautions or actions people should take when registering, or should they be seeking a certain type of vaccine over another if they have anaphylaxis? Margie?
Yeah, so this is very carefully sought when you go to get your vaccine. It's very clearly asked, you know, have you had any reactions or do you have any allergies? And so generally the only contraindication or the reason not to get a COVID vaccine is if you've had anaphylaxis to a previous COVID vaccine, which of course most people haven't, or anaphylaxis to drugs, 2 or 3 drugs or reactions. So there's actually very few reasons why people can't get a COVID vaccine. And most of the time it just means they have to be observed for 30 minutes as opposed to 15 minutes. And really importantly, people who have had anaphylaxis to foods or environmental allergens, pollens, those sorts of things, they're actually at no increased risk. So yes, they will be observed a bit longer, but the vast majority of people can safely get the COVID vaccine, and it's clearly screened for, and people are clearly sort of advised on what to do. So it's actually really well managed, I think.
Another health-related question from Hiroko. I have huge concerns regarding the Astrazeneca vaccine as it delivers DNA into the host nucleus. Are there any causes for that concern at all?
I might answer.
Yeah.
Absolutely no cause. The AstraZeneca vaccine is not DNA. It's a viral vaccine. So it's actually a chimpanzee cold virus. So it's not DNA, doesn't integrate into your host genome. It just carries a little piece of the coronavirus into your muscles, and you get instructions to start making that particular piece of the coronavirus, and then the chimpanzee adenovirus will eventually disappear. Your body actually makes a response to the chimpanzee adenovirus, which may limit the number of doses you can get over time of AstraZeneca, but it definitely is not a DNA vaccine and it doesn't integrate.
Okay, thank you. We have a question from the floor.
Yeah, hi. Look, I really agree that it's important that we don't have misinformation on the vaccine, which is why I went to the OzPAR report by the TGA on the AstraZeneca vaccine. And it says here that the duration of protection has not yet been established. It also says that the level of immune response that provides protection against COVID-19 is unknown. It also says that safety in subgroups, including the frail elderly, immunosuppressed, is unknown. And there's limited data available for the efficacy and safety in individuals with significant comorbidities, and that there's limited data available for the efficacy and safety in individuals over 65 years of age. It says that you should continue to follow other official recommendations to prevent the spread of COVID-19. So I'm interested in your thoughts on the rollout into aged care homes, which are very frail and vulnerable, the ones that we wanted to protect to begin with, given it's quite clear here that it doesn't seem to offer protection. So
Okay.
straight from the horse's mouth.
Thanks
so
for the question.
We'd really like a response.
Terry would
Yeah,
like to answer.
I'm really glad you brought that up. That was the TGA verdict, if you like, at the time of licensure. And since then, there's a huge amount of data now which does address those concerns that at the time were expressed in the extracts that you've just read from, where they weren't saying it shouldn't be used, they were saying there is insufficient data to be confident about. And that happened also in France and in Germany with the AstraZeneca vaccine, where the regulators there didn't license the vaccine in 65s and over, not because they thought it wasn't safe or wasn't effective, but because they said, normally we'd expect some more data. This company hasn't yet produced the data to convince us, and so we're going to draw a line and say, until you provide us with that data, we won't license it, but it doesn't mean don't use it. It doesn't mean it's not safe. And the TGA is very much the same in the language that they've used in what you've just read. Now, since that time, we now have data in the elderly, in the frail elderly in particular, with the AstraZeneca vaccine from the 3 studies I mentioned before, in millions of individuals who have been immunised in Scotland, in England, and also another study in the frail elderly 80 and over, just published last week from Bristol, which has shown very, very high protection against hospitalisation in the frail elderly, so 80 and over, who have other conditions which make them at particular risk of complications from COVID. So the TGA's, if you like, licence had a precaution at the time which basically said if you're going to use it in over 65s, do it carefully and in consultation with your caregivers and understand that it's a benefit-risk judgment you're making here. The uncertainty here traded off against what we expect would be the case for protection. And what you didn't read was also some of the evidence which was submitted to TGA was the antibody studies in the elderly, which show the elderly do in fact produce a very, very good response, which is very likely to be protective, again now shown in these real-world studies that I've mentioned before. So I don't think that you should really misinterpret the way in which a very cautious evaluator, a regulator, uses language not to over, if you like, cook the cake, that basically is cautious about the way it reaches a conclusion. But all the regulators around the world effectively produce a decision at the end of benefit versus risk, a summary judgment that in all the circumstances that we're considering here, we believe the benefit-risk equation is favourable, and that's what they did too. And it was also a provisional licensure, so that licence I think is only for 2 years, and they are now continuously reviewing all of those data. If they had any further concerns that would lead them to revoke that licence, I'm sure they would do that.
Thank you very much for the question. I've got a question online from Mark, pretty practical one. Would I still require a COVID-19 test after both vaccinations if I have symptoms? Sharon?
Definitely, yes. So at the moment we talk about how good these vaccines are in preventing severe disease, hospitalisation and death, and they're 95 to 100% effective. Protecting against mild infection or even asymptomatic infection is also looking promising, but we definitely know that they're not 100% effective. With Pfizer, for example, after the first vaccines, maybe about 50% protective against asymptomatic infection. After the second, about 75%. So there's still a chance that you can be carrying the virus in your nose. So really important. And we just saw a great example of this. Exactly the hotel worker in Sydney had been vaccinated, I think, and 10 days later developed symptoms and went and had a test. Really important. At the moment in Australia. It may change as we go forward, but at the moment.
Julie asks online, if someone has been infected already, if they'd had the virus, is there an advantage to getting a vaccine, or will they be protected from infection because they would have developed antibodies to the actual virus? Janine?
Yeah, it's a great question that we get asked a little bit. Thankfully, as Terry was saying, not as often as my colleagues in America do, because there aren't as many people who've had COVID. But we know that you can catch COVID twice. And therefore the recommendation is that you may get a benefit from having a booster essentially from the vaccine. So the recommendation is about 6 months at least since you've had COVID, which would be for most of the people who experienced COVID here in Australia, that getting the vaccine course is a helpful extra protection for you.
I want to turn to some of the misinformation we've all heard about, read about, the vaccines altering our DNA, the vaccines being a way of inserting microchips into us. I mean, it's out there. It's quite amazing and staggering, the stuff out there. Lots of questions from our pre-registered guests along these lines. I'll distill it into one or two. The first one is a very simple one. How do we work to overcome all the conspiracy theories, the bad science, knowledge and misinformation? And allied to that, how do we as community workers work to gain confidence of those in the public who have little or no science education and read this misinformation on Facebook posts? What's the best way of cutting through, Margie?
Look, I think really when you're talking about misinformation and conspiracy theories, it comes down to trust. So it's actually as much who is talking about the concern and addressing the concern as what is said. So people in specific communities or groups who have particular concerns, and a lot of these conspiracy theories do sit in particular groups. So for example, Indigenous communities have specific concerns and certain ethnic communities do. So the best people to really communicate with them are their own community leaders or their faith leaders. So I think we can certainly help and provide the evidence around these conspiracy theories and the information, and then it's really, they need to communicate within their own communities. But in terms of addressing misinformation, it's clearly about, countering that, that misbelief and then giving the clear evidence or the facts to replace that. And, but people are only going to be receptive to that and receive that information if they trust the person delivering the message.
You'd be staggered and amazed. In fact, you probably receive the same emails, and we get all sorts of weird stuff with weird theories. Does it, just a simple question, does it really amaze, stagger you, the amount of wild ideas out there and dangerous ideas about the vaccines?
Oh yeah, and we saw it with COVID itself, of course, as well. But I think Margie has some good data on this is relatively rare, the extreme.
Absolutely. So when
misinformation.
you're talking about people who have very extreme views, or very extreme refusers, if we look at what we know with parents, it's about 3% of parents are true refusers. Most people are what we call hesitant. Although now I feel really, people have a right to be hesitant and have questions, and that's why we're here tonight. But those more extreme views are actually more uncommon. And to be honest with you, a lot of people in those groups can't be reassured, who have very extreme views, as you said, about 3G networks or about microchipping and so on. So I think all we can do is provide what we know, provide the evidence, and then it's up to people whether they choose to accept that.
Now I'm worried, Margie. I thought it was 5G. I have to worry about 3G as well.
Yeah, I've probably got it
But your
wrong.
experience with those 3% is they rarely move, right?
That's
Yeah.
right. So the
Yes.
vaccine refusers, in our experience in childhood vaccination, it's very hard to shift them. I work in an immunisation clinic most weeks, and I speak with parents who have concerns about vaccines, and I know from experience that people who hold very extreme views, as I said, it's hard to shift them. So we always keep the door open. It's really important to have respectful conversations, to listen. But I said it's those, hesitant people or sitting on the fence. People, many people here today with questions. There's a lot of we can do to help those people change their mind and receive the information. Yeah.
We have a question on the floor. Yeah, please go ahead.
Thank you for all of your very interesting and clear answers to our questions. My question relates to vaccine equity. Given that Australia has a surplus of vaccines, I think I read more than enough to vaccinate everyone in the population twice. What are your thoughts on providing this surplus to low-income countries, maybe regionally, maybe elsewhere, after the at-risk groups are vaccinated, so possibly a bit earlier before your young, healthy 30-year-olds are vaccinated?
Superb question.
Great
Yes.
question.
Who'd like to take up the batting?
I'll go first. So yeah, my personal opinion, I think that's actually important for us as a country to have this exact conversation, morally as a country, but also even just medically, that this is part of trying to control COVID in our region involves us to take a leadership role in that. I think it's a really important question. And you're right, it's about access to vaccine and is probably some of the key parts. We also, as a medical fraternity, have over time had groups heading out to the different countries to help with the administration and those sort of things. So there's a lot of parts that we'll be able to help with. And I think our support for the COVAX facility, which was the I think of it as the co-op for COVID vaccines, which will potentially help provide vaccinations to low and middle income countries, is helpful as well. But I think it's a really important question.
The hard edge question is when.
Yeah.
What about now, when I haven't been vaccinated? I have to wait in the queue. I might be another couple of months before I get vaccinated. Some of you might be surprised at the colour of my hair when I say that. Could be. And Sharon hasn't been vaccinated yet either. So should we be distributing to some of those countries elsewhere in the world that currently have high rates of disease? We have no disease, effectively. That's the real equity question, I think. And I don't have the answer to that, but that is a very hard one. For a domestic situation, to convince the population that we should put some of our own population at risk to protect those in another country is a pretty hard ask for a political agenda. But that is really the question. Ultimately, there'll be more than enough vaccine for Australia to contribute huge amounts to Asia Pacific and elsewhere. And CSL being able to produce the vaccine at 1 million doses a week is going to be a substantial contributor to that in due course.
Thank you very much for the question. Yes, sir.
My question also relates to the rollout of the vaccine. So, Janine, is there any merit in the thought that given it would appear that the hotel quarantine situation is sort of the weakest link in the system in terms of the virus escaping to the community, that we consider vaccinating Australians who are currently overseas, say in embassy hubs or something like that, that they get vaccinated, they wait the amount of time that's required, test negative before they return to Australia, could perhaps get a lot more people on the plane, and then when they return they don't actually have to go to hotel quarantine. Has the panel got any thoughts on that?
Yeah, I think it's a great thought, and I'm sure down the track as vaccine access increases, particularly internationally, that there'll be a push for people getting vaccinated before you come to Australia in general. But you know, the timing and the processes of doing that is hard, and I certainly don't want to be in a situation where you have to have had a vaccine if you're an Australian and you want to come home. And so it's a real balance, I think. But you're right that the hotel quarantines are kind of our weak spot, given this amazing situation we're in, that we can all sit in this room and have a conversation.
I might add to that. I think it will reduce the risk in quarantine. It won't eliminate the risk because the vaccines don't protect you 100% against getting infection. I think about it as sort of infection in the nose or infection in the lungs. So it doesn't reduce your risk by 100% of infection in the nose. So at the moment in Australia, where we have this no COVID policy, that is the other big policy question. You know, when will we change from a no COVID policy to accepting some COVID but pouncing on, you know, severe or symptomatic COVID. So while we have a no COVID policy, there's a risk that a vaccinated person can still be carrying the virus into Australia. So I'm not sure it would help us logistically, but over time we'll learn more about how common that is, and maybe if you're vaccinated and you get COVID, we know already that your amount of virus in your nose is lower, so that's good, you're less infectious, you excrete virus for shorter, so you know quarantine time could actually be different to someone that's vaccinated carrying COVID.
When's your view as to when Australia should move from this no COVID policy to increasing our I guess, tolerance threshold for infections?
Yeah, I don't really know. I'd be interested in the rest of the panel. I don't know the answer to that. Certainly a high percentage of our population will need to be vaccinated, and I think we will learn a little bit more from other countries that have vaccinated very widely and then seeing the impact on transmission. That's really what you want to see. And you know, put it simply, I think vaccines we're using vaccines to prevent people getting sick from COVID. I'm not sure we're going to be able to completely prevent COVID, and we're not going to be able to eliminate it. When will that happen? Maybe in the next 6 to 12 months. I think it's very unlikely that we could live like this for a extended period of time when a large percentage of the population is vaccinated and really limiting movement. But others may have a different view.
The other issue is the variants. So if the variants do turn out to be a problem, then that may well make a difference to what you've been vaccinated with already, and whether you've had a booster from a variant, you know, a vaccine directed against a variant. So there are quite a few unknowns, which I think is what Sharon's saying. We're making a fairly, I shouldn't use the word shaky to be politically very unacceptable, we're making a very cautious and safe start, is what our political leaders say at the moment, rolling our vaccine program out. I'm impatient by nature, but impatient to have Australians vaccinated as quickly as possible. I personally don't think we should do this slowly. I think we should move as quickly as we can and get it done. It also sends a message to the community that we believe this is worth doing, and not waiting around and seeing if it's going to be as safe as they say and all that sort of stuff. Let's do this because we're utterly convinced that the evidence is strong to do it. Let's do it and get to the point where we can really move forward, including opening the economy, dealing with these questions of travel.
And opening the borders, quite a few questions about when can I hop on a plane again. October seems to be the date that is being talked about now as the borders being reopened. Qantas is aiming for that, various people in the government. Is that in any way realistic?
Does anyone know?
It's a hot question.
I'm not sure whether that's Qantas's view of the world.
Well, they'd like to, obviously, and most airlines would like this international travel happening sooner rather than later.
Well, I think it won't all, of course it's not going to be all or nothing. So we're already hearing about these bubbles with Singapore, a bubble extended New Zealand both ways, we hope, maybe Korea, China, countries that have got very little COVID circulating. So that may be the first step.
Yep.
And I also think that quarantine at the moment is very rigid. Everyone goes through the same process. And over time, we may think about stratified quarantine, people at high risk and low risk. So I think there will be travel because there'll be, will it be unlimited wherever you want, going backwards and forwards like we did? I'm not sure we'll have that by October.
No.
Right, yeah. Damn. Yes, question on the floor.
I'm interested in the future of vaccine technology, and obviously the new mRNA viral vaccines are a huge step forward. Is that the way vaccines are going to be in the future, or is there going to be a role for the traditional sort of viral vector vaccines?
You might want to.
I'm happy to start. Sharon will have a view too. We talk about this a lot. Thank you for the question, because the scientific revolution that's put us in such a good position now compared to where we were just prior to the start of the COVID thing, having several vaccines is an unbelievable achievement. We could not have imagined, honestly, that we would have been where we are now with this. And the reason was that some sensible planning, science that evolved, HIV research had a lot to do with actually bringing some of that technology forward quickly. There were some other international collaborations, a thing called CEPI, which was a coalition for epidemic preparedness and innovation, which started investing in some of the platforms that have given rise to these success stories, including mRNA. It's very likely the mRNA vaccines are going to open up all sorts of possibilities for other diseases, other viruses, and also particularly for having a single vaccine that might protect against several viruses. It's very easy to put more than one mRNA into the little lipid nanoparticle. It's all degraded within a couple of days. It's not like a protein. It's unlikely that that would increase the reactogenicity, the side effects and so forth. But you may well be able to immunise against 4 or 5 different viruses with one vaccination. The other thing just about the types, the traditional vaccines, one of the questions on the screen here we'll probably get to in a minute is about why have we only got 2 vaccines? We've actually got 3 vaccines. Novavax is the third. And the Novavax is the third different platform. So Pfizer is the mRNA platform. The Astrazeneca is an adenovirus, a vectored adenovirus vaccine. And the third is the more traditional recombinant protein, which is the Novavax. The early data from Novavax look very, very good, but we won't know for sure for another month or 2. But that is going to give us a third, if you like, platform against if there are future issues with any of these vaccines that we don't yet know, including maybe long-term, if there are going to be long-term adverse effects, which we don't like. We've got 3 horses in this race, which I think is a very, very good position to be in. But it's a fantastic opportunity. The world is going to learn a lot of things from COVID, not just about the science of viruses, but about how we work, how we live together, our values and travel, all those things which are being affected, profoundly is going to affect our lives in many different ways, including opportunities for new vaccines as well.
Sharon, did you want to?
Yes, no, I'm just ecstatic about these changes. mRNA vaccines have been developed initially for cancer, but then, as Terry said, have been worked on for HIV and Zika and influenza, and only small studies. mRNA always looked good in animal models, so I was just absolutely at the edge of my seat to see whether they were going to work in people, and they've just been spectacular.
Brilliant, yeah.
And but people are now working on mRNA vaccines for malaria, or for tuberculosis, or non-viral vaccines. And there's a whole other story about other advances in COVID that we haven't heard that much about in Australia because we haven't been in desperate need for therapeutics. But a really clever way to treat people with viruses is not to use drugs, but to use antibodies. You actually manufacture the antibodies. You can sort of mimic people's bodies and make antibody manufacturing factories, and they also work really well, it looks like, for COVID. They're expensive and they're a bit hard to deliver, but that will also really change the way we do drug development as well. So the science is spectacular. When you put 7 billion people onto a problem and have unlimited funds, this is what you get.
Michael, also just to add with the
Get things
mRNA
done.
vaccines, I think it's so exciting, as Sharon says, and so incredibly clever that you can use a little piece of genetic material in a lipid nanoparticle, as Terry said, a fat bubble that dissolves when it goes into the cell. And then the cell can actually read that piece of genetic material to make the spike protein. And that's what the immune system actually reacts to and makes the antibodies. But people are very concerned about these vaccines, I think, because, you know, they are the first time they've been used in humans. But actually, as we've been talking about at length tonight, they work incredibly well and they do look like they're very safe. So, but it's the most common question that we get asked, is just this real concern about the mRNA vaccines because they haven't been used in humans before. So, but I agree with Sharon, it's incredibly exciting.
Jill asks online, is Australia at greater risk of the disease as we now head into winter in June, July, August?
Absolutely. You know, another reason for my impatience at getting this rollout done, and also my impatience to be sure we have high levels of flu vaccine uptake. You know, look at what happened in the Northern Hemisphere. A lot of that was to do with much less successful social distancing and public health organisation than we were able to achieve here in New Zealand, Taiwan and other places. But really, winter does appear to, it has indirect effects through people being indoors and being close together and so forth. There may be other effects that we don't fully understand, but there's no question that winter is a bad time for a virus like this. So yeah, I'm worried, and I think we should be thinking about that and getting ready as we move into it now.
The race is on. We have a question from the floor, sir.
I'm somewhat of a pessimist, and I'm just wanting to know if the immunity does not last very long for these vaccines. Are we going to have more boosters in several months and then have the whole system start all over again? And do you think that this is going to teach the world a little bit more of how to run these programs? And will it do very much for Australia as far as the next time it occurs? And it's going to occur again, I think. Not with COVID-19, but with another. And I'm just wondering if that's what the panel would think about that.
Great questions, especially on the longevity of the vaccine, I guess. Anyone you want to pick that up?
Yeah, we don't know the answer to that in brief. The longest follow-up is around of antibody levels, and we're assuming that if you make high levels of antibody, you have protection. Pretty good assumption based on what we know in natural disease and in animal studies. But the antibody levels stay very high, don't seem to wane for at least the first 2 to 3 months. We haven't had follow-up for 6 and 12 months. I would expect they will not wane, and that you may well have, because when you actually get re-exposed, your antibody system's all fired up and educated how to respond to COVID, and then you get exposed, the antibodies really take off. So the reason why you might need boosters is more about this issue of variants, and that's why you have yearly vaccines for influenza. It's not to boost your immunity, it's because you need a new vaccine for the new variant that's circulating for influenza. So we just don't know the answer to that. The other question was, will we be better prepared? I'm very confident we will. And actually there has been a lot of discussion about pandemic preparedness. Michael mentioned I run this network in Australia called Prize. It was set up in 2016 for pandemic preparedness as a response to swine flu, which was in 2009. But you know, it was small scale. It was a $5 million entity. It wasn't a $5 billion or bigger entity, which is probably what we need. I think some of the real weaknesses are around how we work across countries and vaccine manufacturing and distribution. That's shown a real weakness as we've seen everyone scramble to have vaccines for their own countries. But probably a bigger question will be what we can do to prevent the next one. Everyone does say, and I agree, it's likely we will have another pandemic, but what can we do to think about preventing the next pandemic? Probably just as important as being prepared.
They only happen every 100 years, don't they?
We'll be
If
going.
only.
Yes, sir, from the floor.
Thank you. I'm with Terry with this one because I'm working with public house residents and they being impatient, when can I get my jab? How's the logistic actually working right now, and how's the logistic will work in the future? Will they get in the pharmacy or chemist or, yeah? That's kind of question.
Janine, good question.
Yeah,
Thank you.
it's a great question. And I think it will be, I hope, it'll be the way that suits them the best. All right, so we're hoping to develop, for instance, obviously, as I said, we'll have big clinics. These clinics have started last week and will continue to expand, will pop up around Melbourne, so that people who are mobile and happy to go to a centre like that will be able to get their vaccine there. They'll be able to get them at GPs, some GPs, not every GP, because it will really be the GPs who have the capacity to do that, to handle the vaccine and handle the throughput, but that will be the other option. And then I think we're going to need to get a little bit creative about how do we provide vaccine to people who are homeless, to people who are largely housebound. And we're thinking very hard about that at the moment. You know, using the resources we already have, the health services that already go out and help those sort of groups access vaccination, or care, and then piggybacking onto that to provide vaccine. So it is the kind of next step. I guess the obvious early answer is to create the big vaccination centres that can pump through, 10,000 people a week. But I agree, I think it's really important for those other groups that are a little bit trickier.
I was also just going to add that in primary care, so we know that the vaccine sort of really, as of next Monday, is going to be run through, general practice for those practices that have, put forward an expression of interest and are now onboarding now and registering, but also through GP-led respiratory clinics, but also some of the Aboriginal community-controlled health services and pharmacy. And it looks like with general practice, there'll be initially about 1,200 general practices around Australia, which in a few months is going to ramp up to about 5,000 or so. And they're all onboarding now. But the biggest question I think people have is, well, how do I book my appointment? And that seems to be a mixture of both a central online booking system that will come into effect in the next couple of weeks, where people will be able to enter their eligibility and their address and then actually find a general practice or one of these locations, a pharmacy or a general practice close to them, and book an appointment and a time for both doses. Or they'll be able to go to their own general practice, and those practices may reach out with either phone calls or text messages or letters. So there'll be both systems, but not everyone has a general practice that they are very attached to. So I think there has to be both ways for people to actually get a vaccine in primary care. But this will all become clear in the next few weeks, so people will be able to book their appointment.
Thank you for the question. We've got less than 10 minutes to go, so last opportunity to ask a question or forever hold your peace. Mirabai asks online, and it aligns with quite a few questions we have already. Is there any data on the vaccine and if it can cause long COVID? And I guess in answering this, for people who might know, what is long COVID? Might not know, what is long COVID?
Well, long COVID is prolonged symptoms that follow an episode of COVID, which are diverse. They can be non-specific, like fatigue. They can be respiratory dysfunction or being short of breath. It can be heart disorders. It can be neurological disorders. And there isn't really an agreed time frame, but this can extend for many months. Long COVID is not uncommon. It's estimated to occur in about 10 to 15% of people with COVID, and a greater chance of occurring with severe COVID than with mild COVID, and can really be debilitating. In fact, the US have just announced a $1 billion investment into understanding long COVID. So I think the question was, can vaccines prevent long COVID? Well, vaccines prevent you from getting infected, but a small percentage of people will get infected. If you are infected, vaccines cannot cause long COVID. But if you're vaccinated and you happen to get infected, does your chance reduce of long COVID if you were infected after a vaccine? We don't know the answer to that. I suspect it will reduce the chance, because you will reduce the chance of severe disease, which is associated with long COVID.
I suspect the question might have been, does the vaccine cause long COVID?
Yeah.
And as you said, important people understand the vaccine is not giving you the disease. It's not giving you a small dose of the disease against which you develop immunity. It's showing the immune system enough of what a virus looks like to allow it to produce antibodies and then store a memory of those for the future, so that if it's ever confronted with the virus in the future, it'll know what to do about it. But this misconception, that with many other vaccines as well, people think you're actually giving you the disease. It's not a live virus. It's all these other platforms we've been talking about. For live virus vaccines, sometimes there are legitimate questions. So, for example, measles is a live virus vaccine, but it's attenuated, so it's designed so it won't harm you, but it's very different. All of these COVID vaccines are not live vaccines. They're all killed or some other form of modification like mRNA.
I've got one final question from the floor.
Okay, thank you. In regards to hesitancy or encouraging people to take the vaccine, in Israel they have a green pass system, and in Saudi Arabia they have an app as well, whereby if you have not been vaccinated, you effectively are not allowed into shopping malls, you're not allowed into gyms, you're not allowed to take part essentially in public life. I know the government here has said it's not mandatory or compulsory. What are your thoughts on the likelihood of Australia rolling out a similar system to encourage people to take the vaccine?
I think the likelihood of the government mandating COVID vaccines is incredibly low. There are so many other things that we can do to encourage people to get vaccinated. What was that?
That's my point. Mandating it via law won't happen. But if apps get rolled out where you are effectively not allowed into public events unless you're vaccinated, then that's a way for the government not to mandate it, but it's a very big stick.
Look, I think from what we know from childhood vaccination, you know, for example, with the no jab policies and trying to use some of those sort of strategies to increase vaccination rates, I think when we're really struggling to get coverage up in the community, sometimes we do turn to some of those more kind of punitive measures, if you like. But I personally believe, and I know, you know, most people believe that there's a lot that we can do, and we're not at that point now. Honestly, we're at the point now where we're addressing questions, we're answering questions. I'm not aware of that sort of punitive approach being planned for from the Commonwealth's perspective, and I'd be very disappointed actually. I think we need to use lots of carrots and answer questions, encourage people to get vaccinated, establish it as kind of the social norm, if you like. So I really don't think, I mean, there may be requirements, for example, in some workplaces. So if you work in an ICU or you work in an emergency department, to work in that environment, you may be required to get the vaccine from your employer. But if you choose not to, you could be deployed to another part of the hospital, for example. So there may be requirements in workplaces, but a very punitive approach like that, I would be disappointed and hope we don't get to that for a long time unless we are struggling to get coverage up in the community.
We're just about out of time. I'm going to pretend I'm David Spears and ask for final observations from the panel before we go. Mid-March 2021, the vaccine rollout is underway. I'll start with you, Sharon, then move through the panel. How are you feeling about things as we look ahead to the next 6 months, 12 months? How confident are you that we've got this?
On the vaccine?
Yeah.
You know, I'm a little disappointed it's been slowish the first 3 weeks, but I'm reassured when I look around the world and countries like, well, the US and the UK also started a bit slow. It's a bit of a problem with supply and it's a bit of a problem of getting our system working. But based on how Australia normally delivers vaccines and the sort of country we are, I'm really optimistic it will ramp up quite quickly once we get it all working. And once the vaccination is our ticket out of, not back to normal life, but out of where we're living right now. So I'm optimistic we're going to get there. It started a bit slow, but I'm just like the rest of the world, I think we'll ramp it up pretty fast.
Margie?
No, I agree. I think we're in a really strong position. The rollout has been a bit slow, but there's, you know, very strong plans in place, and I think we will get there. We are going to have to be patient. We are finding out new information each week, but, you know, there's strong communication, I think, to the community to try and explain what's happening. And the other thing I would say is I feel really confident in our vaccine surveillance systems in this country. I think we're incredibly lucky. In Australia, we have an active surveillance system through the TGA and through Ausvac Safety, so we know that we can track adverse events in the community and we can link to hospital data sets to look for more rare adverse events. And we also have passive surveillance systems where people can actually ring up and report either to the TGA or in state-based systems. So I really want to reassure people that, you know, we will be tracking vaccine safety incredibly carefully, and so that, you know, these blips are going to happen, whether it's blood clots or other potential adverse events, and that they will be looked at incredibly carefully. And just we want to do everything we can to really build confidence in the community.
I know, Terry, I know you want to supercharge the vaccination. What's your final observation?
The state government and others will say we're actually doing better than we had planned, because in fact their targets were exceeded what had been set in this first week or two, which is a great credit to all those involved. So I wouldn't want to in any way be critical of that. It's not about that. It's about how ambitious we need to be, and I do think we do need to be more ambitious. Personally, for the reasons I mentioned before, I do think we can't rely on general practice alone. I just don't think there's going to be enough capacity. And also GPs have to look after all of us with all the other stuff that's going on, normal general practice and healthcare and so forth. We are going to use in Victoria probably what's now being called iconic locations, so big venues to actually have high throughput. A lot of people have already made up their minds. They just want to get the vaccine done and out of the way. They don't need to have a long consultation. They're very happy if it's done professionally and safely and well to come to a and this has happened in the UK. It's happened all over the world. I think we can do this. It's not rushing things. It's not unsafe to do this. This is just getting to our targets in a way that's going to, I think, put us in a better position for all the other benefits that will flow down the track.
You'll be going back to the coalface tomorrow morning, Janine.
Yeah,
How do you feel?
I feel really optimistic. As Terry says, that our sort of northeast region that I'm looking after, we are ahead of where we wanted to be. I know that feels very slow when you're the person not getting the needle, and I know that's ironic for the person who has had them. But we really are going, and I can see the dramatic increase in capacity for vaccination coming up even in the next 1-2 weeks. And I think once people start to see tens of thousands of their compatriots getting vaccinated, we'll really start to realise how incredibly fast this can go. I'm also really optimistic of people, as you say, wanting the vaccine, and I think that we're having really important discussions about vaccine hesitancy, but we know, for instance, in the aged care setting, we had that great question about this before, that the vaccine acceptance rates are around 95%. It's really, really high. And I think that that's going to flow through the whole community. So I'm really optimistic that you won't be in Italy by October, but but you might be
November?
there.
Singapore.
Yeah, we're going for November.
South Korea.
Yeah, I'll happily stick to the Surf Coast. Hey, we're out of time. I firstly want to thank our audience here for turning up. Thank you so much. Thanks for the great questions to our audience online. Thank you as well for taking the time to tune in. I'm pretty sure it's the first time this sort of town hall type event has happened with such a great group of experts. So I thank everybody for contributing to improving public knowledge about the vaccine programs, but in particular our great panel, Sharon Lewin, Margie Danchin, Terry Nolan and Janine Frelin. Thank you so much, and please make them very appreciative. Thank you. Just before we go, for further information on the vaccine rollout in Australia, please of course visit health.gov.au. I'd also like to thank all the philanthropic supporters of COVID-19 research here in the room, thank you, and watching at home because of you. These institutes and collaborators right throughout the Melbourne Biomedical Precinct, a world-beating biomedical precinct, have been able to make incredible strides in their research, and that work continues. Now, if you'd like more expert insights on COVID-19, the Doherty Institute, you'll be pleased to know, is launching a brand new podcast. Very exciting, Sharon. It's launching this week. The first episode is called Infection and Immunity, Evidence Explained. In fact, the first series is going to focus on vaccines, and it features the one and only Peter Doherty, which is great. So subscribe to that wherever you get your good podcast. Episode 2 will focus on Dan Murphy's opening hours, I believe. Sorry, that'll never get old, that. So look that up. I'd also like to, of course, thank the Melbourne Convention and Exhibition Centre for sponsoring this event. The centre welcomes events of all shapes and sizes, from meetings to conferences to exhibitions, concerts and galas, whether in person, virtual or hybrid. It, as you have already seen, has beautiful spaces and really great people in the business, and are happy to host as many events as possible once the events can be rolled out again. And just very finally, this event has been recorded and will be available on the Doherty Institute's website later this week. Once again, Thank you to the panel, thank you everybody, and have a good and safe evening. Thanks for coming.
Thank you.